Thanks, Charlotte. Welcome, everybody. Thanks for joining us today. You're at the BMJ Future Health webinar on adopting generative AI in daily clinical practice, what role for large language models in healthcare, and who's using them already. So we're going to get started in a couple of minutes. We'll just wait for attendees to join in, but hopefully you're all in the right place. In the meantime, feel free to say hello in the chat box. Let us know where you're joining from. And do be aware that the chat box will be used for Q&A throughout the session. We'd really like this to be a conversation between yourselves, Simon and Niels. So do keep those questions coming throughout the session today, and we'll try and make sure that we pick them up. Got a couple more people just joining in, so we'll just start in a minute or two. Welcome, Stella. Excellent role modelling of introducing yourself in the chat. I hope it's a nice spot between London and Cambridge this morning. Now this afternoon, in fact. And all the way from Abu Dhabi as well. Welcome, Imran.
Gonna have a broad spectrum of geographies, I think, aren't we?
Yeah, exactly.
Brilliant.
Got lots of local supporters, I think, Niels. I'm seeing a few towards the Cambridgeshire way. Brazil, less local. Brilliant. Okay, well, I suggest that we'll get started. So welcome and thank you so much for taking time out of your day to join us for this conversation. I'm Jenny Shand. I'm a professor of applied health research at UCL and delighted to be moderating this session. So as I said earlier, my role is really to ensure that your questions are covered and answered by Niels and Simon, and that we can facilitate a conversation about what is a really growing topic of generative AI and how we might use it in clinical practice. What are the opportunities? What's the benefits? What's it look like? BMJ Future Health, if this is your first session with us, it's a new community that consists of webinar series, podcasts, and a live event that's happening in November, for which the tickets are now live, I believe. So we'll have a QR code at the end of the session where you can see that. This session will be recorded, so you'll be able to watch again or share it with colleagues afterwards. And at the end of the session, we'll be having time for Q&A. So please do submit your questions through the Q&A box. And if you've got any general comments you want us to pick up on or general themes, please do use the chat openly for that. This webinar is going to really focus about this frontline clinicians and how we can leverage these generative AI tools. And I'm super excited that we're joined by Simon and Niels. So I'm just going to ask Simon, do you want to just introduce yourself to the room? Welcome.
Yeah, hello everyone from all over the UK and beyond. I'm Simon Wallace. I'm actually in Dublin for this meeting. I am the CCIO at Microsoft in the clinical apps arena. I'm a hospital doctor, GP by background, and have been in the digital health space for the last 20 years or so, and delighted to be joining you all today.
Thanks so much, Simon. And in a moment, Simon's going to kick off with his presentation. But before that, Niels, welcome.
Thanks, Jenny, and hi, everyone. Delighted to be joining the webinar today. So my name is Niels. I'm Professor of Data Science and Healthcare Improvement at the Healthcare Improvement Studies Institute, University of Cambridge. My background is in computer science and AI. I've also been active in the digital health space for a long time, and I lead a program of work about developing and evaluating digital innovations based on in healthcare. Sorry.
Brilliant. Thank you, Niels. We're looking forward to hearing more about that and what you're learning so far. Simon, over to you.
Okay, well, let me just share my screen first. So give me one moment while I do that. And just to make sure, let me just go on to Can you give me the thumbs up, Jenny, that you can see? Yep, brilliant. Okay. So over the next 10 minutes or so, I'm going to be sort of focusing on um, where ambient and generative AI has come from, i.e. the role of our voice in creating clinical documentation, and give you some examples of where it's being used and some of the work we've been doing to make sure that this new technology that has had such a buzz over the last year or so is fit for purpose, and it's actually going to meet the needs of clinicians in the NHS. So what's it all about? Why is this so topical? And I think what it's trying to solve is this. This is a painting some of you may have seen before by a 7-year-old girl. She's sitting there on the couch. And she's got her sister with her, her mum and baby daughter. And the clinician, the pediatrician, is hunched over the computer, busily getting all the notes down. The consultation went brilliantly, but and the 7-year-old wanted to show her appreciation and sent this painting, but of course the clinician was mortified that he had his back to her. And I think this is what this is all trying to resolve. We did some research a while ago to try and understand how much of a burden clinical documentation is. And just creating documents, it takes up about a third of the working week. And that has gone up over the last 7 years. And that, I think a lot of that is, one, our healthcare has become more complex, but also the requirements that EPRs are putting on our workflow and our requirements. And I think the other key thing out of this slide is it's contributing to stress and burden. And, you know, whichever country you're in, whichever healthcare system, that has unfortunately become really endemic in our working lives. So just a little bit about the evolution of ambient and where it's come from. Speech recognition has been around for years. And by that, I mean where you speak into a microphone and you see the text come out in an EPR, in a Word document, in your emails. But over the last 18 months or so, ambient has become the sort of the real buzzword. And when I say ambient, I mean that myself and a patient will have a consultation, and what will be an output will be an actual clinical note without the clinician needing to touch the keyboard. Then if you underpin that with generative AI, it gives you so much more interaction using your voice with the electronic patient record, creating outpatient letters, creating referral letters, a whole host of various pieces. Now, if this ambient technology is gonna work, it needs to be available throughout the whole health ecosystem, not just in hospitals, but out in primary care and mental health, and also in the community, in patients' homes. And sometimes connectivity may not be great. So one of the things it needs to do is to be able to record the voice in an asynchronous way, i.e. it stores it. And if there's not good Wi-Fi, then to be able to do what it would have done to create that note when the healthcare professional is back in good connectivity. And it needs to be available across a number of different media. It needs to be available mobile, from your mobile phone, on your desktop, and also particularly through a browser. That makes it a lot easier for deployment of that sort of thing. I think the way that I sort of position what this technology needs to be able to do, I've broken it down to 3 buckets. It needs to streamline documentation. And what I mean by that, it needs to be able to create the clinic note. It needs to be able to reflect what was had as a conversation between the patient and the clinician. And it also needs to meet different needs of different clinical specialties. and different clinician styles. It also needs to be able to surface information. And by that, I mean, I want to use my voice to just interrogate certain factors of the note. I might come back after a clinic of seeing 15 or 20 patients, and I quickly go to that patient. I say, so what was the drugs that the patient was on? And it just automatically brings that up. So I'm interrogating the notes. And I think most importantly, it needs to be able to automate tasks. If you're in an outpatient clinic, 50% of that admin burden is creating the documents, the letters, the notes. There's also the other 50%, which is actually ordering the tests, prescribing the drugs, doing the referrals, the follow-up appointments. And, you know, over the last 15 or 20 years, that burden has been thrust upon clinicians unwantonly. And not surprisingly, they feel that they're doing so much more of that they were not all that time ago. And I think the other key bit, it needs to fit into the workflow of whichever electronic system that's being used. And I think that's a key bit for giving time back for clinicians going forward. So does it work? Here's some data. We're finishing off a whole series of work with results about to come out. This is some data from the US where it's been broken down into operational efficiency, clinician well-being, patient experience, and quality. And if we look at operational efficiency, it's giving time back. And I think that's really important. If it's not going to do that, you can forget it. Clinicians are not going to be interested. And it's allowing additional time to see extra patients. If we get into the clinician side of things, you can see the numbers there are pretty convincing in reducing that feeling of cognitive burden and actually improving that doctor-patient or clinician, healthcare professional, patient experience. And when it comes to the patients, as long as they've been involved in the process, as long as they've been involved with being asked, is it okay I use this technology, they love it. They feel that there's a much greater, more personal interaction with their clinicians. And finally, when it comes to the quality side, it does improve the quality of the documentation. Now, providing it's accurate and it hasn't hallucinated and all that sort of thing, the actual content of the output is much improved. So those are some sort of really important metrics that I think are giving a thumbs up to this technology going forward. Let me just finish with some work that we've been doing in what we call private preview, but it's our pilot, where we were basically focused on taking our model and in the NHS workflows, asking, is it accurate? Does it recognize the clinical terms and the drugs? Is it at risk of hallucinating? And by hallucinating, I mean things that were said between the patient and the clinician. Did it misinterpret that and come out with something completely different? And how well does it fit into the NHS workflow? For example, many on this webinar will know that letters now from outpatients are going directly to the patients with a copy to the GP. So this technology needs to accommodate these shifting sort of ways of working. So what do we do? 7 healthcare organizations over the last 6 months, 10,000 consultations with 200 plus clinicians in a range of different specialties. And we had a group of healthcare professionals. They were clinically trained, who would be reviewing the output of the note versus what was actually said. Plus, there was a feedback tool from the clinicians themselves, so that we could collect all our sort of information to understand those focus points at the top there. And just a few quotes here, and I'm going to balance this with some learnings that also came out of it. And let me just do that. So from the clinician's experience, it was well received and it worked well in the outpatient workflow, giving time back. And I think that was really important. But there was some sort of feedbacks that we needed to acknowledge and to do some work on to improve the workflow. One of the things is that a first appointment is subtly different to a follow-up. So a first appointment, someone comes in with chest pain. It's, chest pain, what's it like? Where does it go? It's pretty straightforward to do. But in a follow-up appointment, particularly if it's a bad news conversation, someone's just been diagnosed with cancer, there's lots of subtleties and a lot of slightly more complex sort of nuances to that. So one of the behavior changes there was to have an overall summary at the end, which was good for the patient, but also was good for the note. Although we were focused on outpatients, clinicians went a bit off piece. They used it on ward rounds, and they found it useful there. And also in ED, actually, was another area. So let me just talk very briefly about clinical specialties and just highlight neurology. Neurology is a clinical specialty. If there are any neurologists on the call, put your thumbs up in the Q&A. But neurologists like to have a lot more of what the patient actually said in their history of present illness. And we were a bit too concise, so we needed to change the model a little bit for that clinical specialty. Plus also, appointments differ. So for a breast surgeon, for example, he'd see the patient, then send her off for an ultrasound scan. So we'd need to stop the recording and then start again. But to make sure that the two recordings came together so that it was a unified clinical note. That also applies for some clinicians do a whole load of pre-recording for their outpatient patients the day before. So they'd do a 1 or 2 minute voice recording, then the next day come back and have that consultation. So workflow is something that's going to be really important. I'm sure will come out in the discussion. Patients, no real issues. We had good interaction there. And then, of course, the other key bit is the security, the safety, the trust that goes with this. I think we'll talk a little bit more about this in the Q&A. But we went through a process, and it took a bit longer than we thought, frankly, all around DTAC, DPIA. These are NHS privacy sort of documents, DCB 129 for clinical safety, UK GDPR, and a range of other things. And I think that's really, really important that the clinical community feel that this technology is safe and patients also feel it's safe. I'm just going to finish. One of the key bits is the opportunity of prompts, writing prompts so you can tailor your needs. I'm not going to go into detail, but there's a real balance between standardization of a note, templates, output versus customization. And there are pros and cons of both. And essentially, there's a need for a balance. There really is a need for that. And that, I think I put myself in the position of providing a toolkit, but down to healthcare organizations to actually have that balance of how they want their templates, how they want their letters to look, and perhaps bringing on board national PRSB standards, that sort of thing. You can see a letter down the right-hand side of the page here, which is a letter to the patient. It starts off with the diagnosis, problem list, and the management plan. We didn't have that to begin with. This came from feedback because that's all the GP wants to see. But this is a letter to a patient. And so it's in a much more personal style. You attended the clinic, your past medical history. Whereas letters to GPs going with a copy to the patient doesn't have that. And then finally, a glossary at the bottom to help the patient sort of understand, what is a CT scan? What does it mean if I'm going to have a colonoscopy? So I'm going to finish. There are lots of players out there with large language models that have been taken off the shelf. One of the key bits of all of this is having a very good general medical model, but you need to then train that general medical model to be more specific for different clinical specialties. in the way I used the example of neurology, I can also apply that to oncology, for example. So the art and the trick, I think, to this working is how good and how well trained the language models are. So coming back to this painting, a colleague of mine used GPT-4o to try and take this painting and start getting the clinician turning back to the family in the room and fully turning back, with this being the objective of this new really exciting technology. So I'll stop there. I will stop sharing and hand back to Jenny, then to hand over to Niels.
Thanks so much, Simon. So much in there, and you'll see that the chat is bubbling with lots of interesting questions. So perhaps take some time to have a look at that while Niels opens up his presentation. And great to end on that patient picture, which in your survey suggested that patients felt that the consultant was at the computer 90% less of the time. So maybe that is happening gradually. We'll hear more. And there are some interesting questions about what's behind some of that survey data. So perhaps we'll get onto that in a moment. And one of the Q&A, we have one question in the Q&A, which is about how do we get more robust evidence about these uses? And that's a perfect segue into Niels's presentation. So welcome, Niels.
It is indeed. Thanks, Jenny. I love that picture, Simon. It just says more than 1,000 words, isn't it? So let me start by sharing my screen. I hope you can see that. Thanks, Jenny. So I'm going to talk about how we can build up the evidence base for the impact of generative AI and ambient scribes, which is quite a challenge. And I think we're only just at the beginning of that journey of building up that evidence base. Before we talk about generative AI specifically, I just wanted to mention that AI in healthcare has a very, very long history. We tend to forget that because we get excited about the newest thing always. At the moment, that's obviously generative AI, large language models, ambient scribes. But here's a paper from 1959, which basically said that we should be able to do medical diagnosis with computers. This was written by Robert Ledley and Lee Lusted, and they argue very convincingly that that should be possible. So that's more than 65 years ago now, and yeah, we're still trying to make this happen. Interestingly enough, I think why it's interesting to also look back at the history of AI in healthcare is that we see recurring things happening. So we tend to get very, very excited about the newest technology. After a while, we get a little bit disappointed and we switch to the then newest technology. And I think also consistently we find that it's really, really hard to translate technical performance into something that adds clinical value and demonstrate that it has that clinical value. So these are recurring themes, I think, across that history of AI in healthcare. Another thing that's, I think, quite typical for AI is that it's often more obsessed about the future than the present. So when we talk about AI, it's always about what is going to happen in the future. And with that is also a history of overpromising. So here are two examples of quite influential people who said something about the future of AI in 2016, and both of that turned out to be not entirely accurate. And Jeff Hinton, by the way, won the Nobel Prize in 2024, but not for this particular statement. A third challenge I think that we have with technology in general, but definitely also with AI, is that it's quite hard to make sure that the AI does the things that users need and not the things that they don't need or would like to rather do themselves. I think diagnosis is actually an interesting example because I think most clinicians would say, if you tell them, I've got something that can help you with, making diagnosis, they would say, well, actually, I'm pretty confident and happy to do that myself, but I would like to have support with other things, the more silly things and mundane tasks. I think actually with ambient voice technology, digital scribes, we are addressing that. So that's a very positive thing about that technology. But we've seen many examples, I think, throughout the history of AI in healthcare, where the technologies were addressing the wrong things, or at least not things that clinician users necessarily need it. And then I think it's important to recognize that the translational pathways that we have for other types of innovations in healthcare, specifically medicines and biomarkers, do not typically apply to digital innovations and specifically not to AI. And that's for a number of reasons. So those traditional translational pathways typically go through phases of discovery, where we develop or discover an invention, then a phase of product development based on that invention, then performing translational research, so phase 1, 2, and 3 trials to demonstrate the safety and efficacy of that product. And finally, a phase of implementation where we start routinely using that product and scaling and spreading the product. So this is typically, for instance, how it works for medicines, and it's very well established. And one of the reasons that it's so well established and tends to work well is that this is also very highly regulated. So essentially you're forced to do it like this. For digital technologies and AI, there is not the same type of regulatory scrutiny, and therefore there's different ways of going from discovery to implementation. That's also what we see in practice. And I think what's also really important to recognize is that for traditional interventions like medicines, in the development phase, basically everything there is to define about the intervention is defined. So for instance, what is it going to look like physically? Who's going to use it? How will they use it? When will they use it? All those things, all those questions will be answered in the development phase. So we already know a lot in that phase. I think for digital interventions and specifically AI, that is not necessarily true. And very often we only start to discover what the intervention really is and how it impacts processes and outcomes in healthcare in that very last phase, in the implementation phase. So only once users start interacting with AI and start redefining processes based on the outputs of the AI and build up experience with using it, I think we get the full picture of what the AI tool really is and how it impacts processes and outcomes. So that makes it also really much harder to go through this translational pathway. It doesn't really work, I would say, for AI. Then I think what's really important also to recognize is that accuracy of outputs doesn't mean that a tool will also have impact and therefore have clinical value. I think we always have to know what the technical performance of an AI tool is, and so what the accuracy of its outputs are. That's absolutely essential. But we might have a tool that is extremely accurate, but still doesn't have any impact. And therefore, it's so important that we also perform clinical studies where we evaluate that impact. There's a nice framework developed by the American Medical Informatics Association, AMIA, where basically they distinguish 3 types of studies that we have to perform for any type of digital tool, starting with technical performance, so assessing the quality of the outputs of the tool, then evaluating the impact on usability and workflows. So how does the tool change how clinicians work, and how can they interact, and do they interact with the tool, and are the outputs, for instance, understandable? And then finally, once we've done that, we can evaluate the impact of the tool on the decision-making processes, for instance, and on outcomes. And in the case of ambient voice technology, digital scribes, we would then think of how would the tool impact the way that clinicians use their time, and how does it impact efficiency of processes and productivity of the health system. Those are the kinds of questions that we would like to answer in that 3rd phase in the health impact evaluation. What do we know at the moment about the impact of generative AI in healthcare and ambient scribes? I think it's fair to say that there are numerous studies that have been published in the last couple of years about generative AI in healthcare. Only a very, very tiny fraction of those actually do address impact. So that means we know very little at this moment in time. Most of the published impact studies focus on things like medical education, patient education, and sometimes also on administrative and operational tasks, including operational tasks and admin tasks with ambient voice technology. But I think it's fair to say that at the moment, there have been very, very few rigorous studies that really look at the impact of such tools on clinical processes and outcomes. So we just don't know at the moment whether these tools do have an impact, for instance, on productivity. And one of the challenges there is also that there are actually not too many methods to assess something like productivity. It's not something that has been rigorously studied in healthcare before. We're now in a position where both in the NHS and other healthcare systems, we would like to improve productivity, but there's not a long tradition of studying that and studying clinician time use. So the number of methods, for instance, that we can draw on is quite limited. So that also creates a challenge in these evaluations. A couple of other challenges that we typically have when we want to evaluate the impact of an AI tool or an AI tool. So the first thing, and this is a general challenge with assessing the causal impact of any intervention, is addressing confounding and bias. So we have to use a design that allows us to avoid that there would be any confounding in the study findings, and therefore the results would be biased. Obviously, the traditional solution to this problem is using randomization. So a randomized clinical trial wouldn't suffer from any confounding. But I think there are many situations where we can't use randomization when we're trying to evaluate an AI tool. So we have to resort then to other study designs, but they are by definition weaker. I think what we sometimes see is that people present the results from a non-randomized study. So basically, all the things that happened when people started using the intervention only without a control group as the impact of the tool. And I don't think that's right. I think we should be very clear that you can't assess the impact of a tool without having a control group, and ideally via randomization. Other challenges, it can be very hard to establish a baseline if the AI tool fundamentally changes processes, for instance. AI interventions tend to be evolving and fast moving, so any study that takes up a lot of time will basically be outdated by the time that it is published. Then there's user attitudes and perceptions which will influence the impact of the tool. And in fact, if those attitudes and perceptions are very negative, then typically the tool wouldn't have any impact. And finally, we've got this challenge of generalizability. So how do we make sure that what we find also generalizes to other settings, other places than where we conducted the study? So we are at the moment here in Cambridge evaluating the impact of ambient voice technology on the GP time use. So we're doing this in general practices across England. And our primary outcome is GP time spent on clinical documentation. And we're trying to assess how the use of ambient voice technology changes that. We're not in a position in this case to do a randomized study. So what we're doing is a before and after study with concurrent controls. And I think that's a robust design to assess this type of question. So we've got a number of intervention practices where GPs will be observed twice, once before they've started using ambient voice technology, once after they've started using it. And then we also have a number of control practices. Again, people will be observed twice, but they will not use ambient voice tech. The measurement of how people use the time is via what we call time and motion methods. So we use in-person non-participant observation. So there's someone in the consultation room observing what the GP is doing. And we use a tool called Wombat, which you see here on the right-hand side. We also have 2 qualitative interview studies assessing a theory of change and work system design requirements for optimal use of ambient voice technology. One of the other things we're doing, and this is one of my last slides, is we're setting up a community called Ambient Voice Innovation and Development. It's hosted on the Discovery platform, and it's a convening place for multiple stakeholders who are interested in the use of ambient voice technology in healthcare, who can there share experiences and promote debate, stimulate problem solving. So we aim to have different types of users and stakeholders in the community. We're conscious that there are many people now who have built up, a reasonable experience with ambient voice technology in their practice, whereas others are just starting. And I think bringing those different groups together will be very useful. One of the other things that we're aiming to do, working with NHS England, is to generate and curate standards for ambient voice technology within the NHS. So let me just summarize the key points from my talk. So AI in healthcare has a very, very long history, and I think it's useful to look at that history also when we're looking at new technologies. The traditional translational pathways, so the ones that we typically use for medicines, do not apply to digital innovation. Technical performance of any AI tool, I think, is really important to assess, but it is fundamentally different from healthcare impact. So we shouldn't conflate the two and be mindful that good technical performance doesn't necessarily lead to impact. And finally, the evidence base for generative AI and ambient voice technology is still very, very weak. It is emerging, but we'll have to wait and see and wait for strong studies before we really know whether there is an impact of this technology on productivity and efficiency. So thanks very much for listening.
Thank you so much, Niels. That's great. And I think in the chat, Stella has highlighted your community. So hopefully everybody managed to write down the address that Niels shared if you're interested in joining the community. And thank you also to Siobhan, who's flagged about an AI nurses network as well. That looks like they have lots of useful resources for training and adoption of AI too. One thing that struck me at the end of Niels, your talk, is AI has a long history. And I think we've used the term relatively all-encompassing. And what do we mean by AI in different pieces? So today we've heard examples of machine learning, of large language models, of generative AIs, creating summaries and different output styles. And I guess there's something about that taxonomy of how do we be clear about what we're talking about in these different contexts. So interested in your thoughts on that, and maybe Simon too, because I think it does change our perceptions on safety and impact, because if you know what you're feeding into it, you can be more confident about how that model is trained and therefore the outputs. If it's this generative AI piece, that feels like more of an unknown. What's your thoughts on that, Neil?
Yeah, it's a really good point, Jenny. Thanks. Yeah, I think so. There are different definitions of AI, and if you look throughout history, they keep changing. And in fact, my favorite definition is AI is anything that we cannot yet do with computers. Everything else, all the stuff that we can do with computers, is just software. I think there's probably an argument for that. I think it's probably true that maybe in 5-10 years, we won't be that excited anymore about generative AI. We would just consider it to be a software component that we regularly use within all kinds of applications. And probably we wouldn't call it AI. And there's all the forms of AI, so rule-based reasoning systems, for instance, that we still use in, for instance, medication safety alerts that nowadays we don't call AI anymore. But at the time when they were developed, they were called AI. So it shifts. And indeed with that, I think also, as you're saying, the safety implications, safety risks, and considerations around workflow efficacy do change. My personal opinion is that we probably shouldn't use the term AI, but I appreciate that's a bit radical.
I'd slightly advocate that of us being more specific about what we're talking about in the different contexts. Simon, there are quite a few questions in the chat for you, mostly around the data that you shared. Obviously, highlighted some real excitement around some of these gains that you've shared on that. Is there more, to Lena's point, about the source of the survey, the number of people included, and also to Stella about a bit more on those cohorts? Is there a published version of this that people can look at?
So that data is US data. So there's a need to sort of put it in that context. But the volume of people where that's come from, I think it was something like, off the top of my head, 400 patients contributed to the to that sort of patient experience. And then there were a similar number of clinicians across a range of different clinical areas from 100+ organizations that got to the sort of the operational, the clinician, and the quality side of things. There's been one study at a hospital called Northwestern in the US, where just looking at the notes here now, their study showed that they saw about 11 more patients per month were seen by each physician in at least 50% of the consultations. There was a 24% reduction in the time spent on notes, and a very American term, but it's 17% decrease in what is called pajama time, which is sort of late night documentation. So yeah, I agree with Niels. There's a real need to sort of build this up, and the work that we did over the last 6 months in the NHS was a stage one of accuracy hallucinations fitting into NHS workflows, and that was really important. And I think the key bit of that journey was a group of individuals who I said were clinically trained, but they were at a combination of at the elbow of the clinician and also taking feedback that came from a feedback button in the app, plus also listening to the voice files and listening to the output, then comparing that to the output. And over that 6 month period, there was iterations of improvement. And I think that was really, really important to get to a point now where we are going to be launching this into the healthcare service in a few days' time. But I think we took our time with it because we wanted to make sure that we'd been through some really good due diligence. And one of the other key things that took a bit longer than we thought was around all the security, the confidentiality, all those sort of requirements that give healthcare professionals and their organizations confidence that this very much talked about technology is safe.
Thanks, Simon. There's a few points actually on that sort of data flows. One around, would insurers see all of the data that's being gathered by some of these tools? No, so that sort of safety path remains as it does at the moment. And there's another question in the Q&A from David about how confident we can be the legal system would accept notes that were generated by AI if somebody was needing them in a case.
Yeah, it's an evolution, isn't it? It's a new way of doing things, and we need to address that. I think.
I mean, my understanding that ultimately it's still the clinician that's signing off that content, so that accountability still sits at the clinician. That's what
that was going to be my next point. Whether it was just using ordinary conversational speech, where you see the words come on page, whether it was typing, it doesn't matter. The clinician still needs to check that. And to actually sign off on that he or she is comfortable that content is what there is. We also have the option that we put at the bottom. This note was created using ambient and generative AI as well. They don't have to put it in, but we're trying to cover all the bases so that people feel comfortable using it.
Yeah, and I guess that then is about transparency with the public as well.
Yeah.
There was one comment, sorry, Simon, there's a couple more for you. One around the point about that co-production. So it sounds quite exciting actually that the clinicians went slightly rogue and took it into ED, into ward rounds, because I guess that shows user-led design. And there's comments about, sort of the, Lucy's mentioned about the patient-focused letter of being a great sort of development. And there's two pieces on that. So one, how are you getting patient feedback on how well that letter's curated, whether it's meeting a patient's need? And secondly, Stella's point around the sort of, does that change the language that's being used so that you're able to create these sorts of outputs more easily?
Absolutely. So to the last point, as a result of our 6 month journey, we have three bespoke outputs. One is a letter to the GP, which is going to have a copy to the patient. The language and the style of that is written in the traditional way that outpatient letters are today. The letter to the patient, there is a prompt that's being created, which describes the type of language. So for a reading age of a 10 or a 12-year-old, using simple non medical language. And so this prompt, of which we've spent many months refining, comes out so it is written that there's a very good chance that someone of a reading age of, say, let's say 10 or 12 is going to be able to understand that. And the glossary at the bottom goes some way where you do have something like a colonoscopy or a word like CT scan. It gives a one-line just definition of what that is. Sure, they could go and look it up on, through Google or whatever, but for the letter to be complete, it's a good way of giving them a good chance of having a much better understanding and being less intimidated by the language that's being used.
Thanks, Simon. That's really helpful. Niels, I just wanted to come on. You shared an example of your time and motion study and evaluating in practice about the use in primary care. And it slightly links to a question that David's put into the Q&A about how well ABT is integrated into established clinical systems. What did you observe in that study?
Yeah, so that's very much still emerging. So in our study, we're evaluating one specific product that's used a lot in primary care, which is not integrated with the electronic health record system. The vendor of that system and the different electronic health record vendors are working together to establish that, but at the moment, it hasn't happened. And I think there's quite a few products on the market still that are not integrated with the electronic health record. There's obviously some risks associated with that. So it means you have to copy and paste content from one tool to the other, things that could go wrong there. So I think integration is always better. I'm sure that isn't going to happen. So in the not too distant future, we will only have digital scribes that are fully integrated with the electronic health record. But yeah, these things do take time.
Thanks, Niels. I think that's certainly the trend we've been beginning to see in the US, where there has been much more integration into these EHR systems. Simon, how's that working with your tool? Is that fully integrated, or is it sort of a standalone?
Integration's key, and we have a partnership program where we work with the various EPR providers to accomplish just that. We're quite a long way down the track with Epic and Meditech, for example, and so much of that is understanding the workflow of those respective EPRs and making sure that the output that we get from our sort of ambient and generative sort of conversation complements that. And I used the word workflow earlier, didn't I, in the presentation?
Yeah.
So much of that is understanding the workflow of that particular EHR and how the output that we produce complements that, and it doesn't add extra burden to the clinician as part of their consultation, whichever arena they're in doing it.
Thanks, Simon. That's helpful to hear. One piece we haven't touched on, but has been, as I guess, suggested out from the edges in some of the discussions in the chat, is about inequalities. So generative AI models are often trained on data sets that might underrepresent certain populations, and the health systems don't always deploy them evenly. We know that dialect and different accents can be a challenge for some of these AI scribe tools, for example. Niels first, maybe, and then Simon, what are your thoughts about the safeguards or strategies that we might need to put in place so that we reduce rather than widen health inequities as the system starts to increase the uptake of these different solutions?
Yeah, it's a really good point. And I think it's a challenging one because we've seen in the past that quite often we only discover years after things have been introduced that actually they are either introducing new inequalities or exacerbating already existing inequalities. And I think AI tools have a specific tendency to do that because ultimately they are trained on very large corpora taken from different sources, which will embed certain societal systemic biases. So we can't avoid that there are these biases present in AI tools. I think in terms of trying to avoid in clinical practice that they would indeed introduce new inequalities or exacerbate existing ones is thinking very, very carefully about the potential ways in which that could happen and have a strategy within your trust or within your practice to address the potential causes of inequalities. So indeed, is it conceivable that a tool that certain patients weren't well represented in the training data for a particular tool? Is it possible that for other reasons, the outputs would be biased against certain groups? So I think clinical oversight of the outputs and what happens with them is extremely important, but especially being prepared for the fact that this might happen and thinking about those potential scenarios, having a plan.
Thank you. Simon, what's your thoughts?
Yeah, I mean, it's a really good point and very important. The model that we started training on had 15 million consultations across a very wide population base. Then during our 6 months, the 7 hospitals which we were working with were in different parts of the country with very different cohorts of patients, as well as clinicians from a number of different backgrounds. So I think we did a good job there, but to Niels' point, it's an ongoing piece, and certainly as more and more users and patients are using this technology, that will help reduce the risk of those inequalities.
Thanks, Simon. And we've had an interesting comment put in the chat by Stella about some people being able to sign up to speak in their first language with their GP and whether that would be facilitated through some of these tools. I understand that some of them do have the capacity to translate into languages, but because of needing the clinician to sign off the outputs, those functionalities are currently unutilized until that sort of pass work through. What are you aware of, Simon, in this space in terms of that language capacity?
I think that's a really golden opportunity. For us in the US, we have Spanish because there's quite a large Spanish-speaking population, and we did not have that as part of our testing when we were doing our 6-month private preview. But coming down the track, that language ability is very much in our sights, because particularly having that ability to do that I think it'll enhance and better the interaction. I've seen it. I've sat with clinicians when there's a relative been in the room and they've been translating and then coming back in English, and how does that work with the voice? It worked really well, actually, but the jewel in the crown would be having that seamless translatory output, so that that would be the best way forward. But that's certainly in our sights. It's been highlighted a lot over the last 6 months.
Thank you. And Lena said that the full license Copilot has that capacity, which feels quite natural. Niels, I guess there's a thought here. So, these things are scaling at pace across different settings of care. Your presentation really helpfully outlined different segments about how to approach evaluations and building the evidence from different perspectives, be that the functionality, the accuracy, and then the impact. What are your thoughts about how we need to be mindful about how this is rolled out in different settings of care? You've shared about primary care, Simon's referenced around A&E and around ward rounds, and obviously they're all very different, and the gains in each of those settings can be articulated very differently. What's your thoughts on how we can help to build this evidence base, coming back to Hannah's original question?
Yeah, I think it's quite likely that the effects will be very, very different between different settings, between different specialties. The opportunity to reduce time spent on clinical documentation, I think, is very different between settings, between primary and secondary care, between outpatient and inpatient settings, but also between different specialties. I think it seems plausible that in some settings, for instance, mental health assessments, there is the opportunity to save a lot of time, whereas in other settings, it seems implausible that there's any time that could be saved. So I think what we will end up with is a very heterogeneous picture where the effects of this type of technology are very different in different settings. So I certainly at the moment, I would encourage everyone to test the technology in their own setting and see how it pans out for them, because I don't think it would be wise to rely on results that were obtained in a very different setting. I think also it's probably wise to consider what the alternatives are, because like any technology, it's not a panacea, right? I know clinicians who say, I don't use it. I typically write one sentence after a consultation. Why would I use ambient voice technology? And they're right. So, and there's alternatives like digital dictation. There exist templates that you can use for notes and for letters. In some cases, that might just be quicker and more efficient. So I would say be critical and keep thinking whether this is what you need to use or whether other solutions are just better for you.
That's really helpful, Niels. And I think an important bit around what matters to the user, often finding that people record and fully transcribe a meeting that doesn't necessarily need all of that detail held on record for the future. Charlotte's just popping in, and I know, Charlotte, you're going to put a slide up. Simon, you look like you just had one last comment you wanted to make.
I think it's a really interesting note to conclude on, because there's a whole behavior piece here, which you know, when we went from pen to keyboard, oh, that was quite challenging. And likewise, we're going from keyboard to voice. And I think we just have to be slightly more open about behavior changes we might just have to do to actually accommodate it. Not that it's should add any more time or anything like that, but there may just be sort of things that we would not have done in the past that actually our voice is giving us greater freedom to do. There was one senior clinician I was talking to a while ago who saw the output of his note and he said, "Goodness me, that's much more detailed than I would have done. I only write 2 or 3 lines." And he was thinking, well, I only need 2 or 3 lines, but the note was actually better. And he said, yeah, I think my colleagues would appreciate that more. So it's being open-minded and having a sort of behavior acknowledgement that things may be done slightly differently in a good way.
So I think we're taking the charge of test and learn and be curious, feels like the
Yes,
headline.
great word. Yes, great word.
Charlotte, do you want to just share the slide? And I'd just like to thank everybody for joining us, and particularly thank Simon and Niels. I think it's been a really interesting conversation. Definitely, I've thought and reflected about some different things than when I joined an hour ago. So I hope you've all found it helpful as well. And thank you all for your participation and for some of those links and those communities that you've put in the chat. On behalf of BMJ Future Health, we're also really excited to announce the live event, which will be in London, and there will certainly be some sessions in the agenda on AI, so you could continue some of this conversation. There's a QR code on the screen, so you can snap that or you can visit the website to get some additional information and to register to join. There's also another webinar taking place in September on the 24th from 12 till 1 o'clock. Thank you, Charlotte. So the details are now on the screen. It's about digital leadership in the NHS with Joe Harrison and Mike Brackman. And I think that'll be a really, really interesting conversation. So finally, thank you so much for taking some time out on your Thursday lunchtime to join us. Thanks for participating. I hope you all found it valuable. And thank you to the partners and sponsors of Future Health, so their strategic partner and learning partner. And Charlotte, I think the webinar is recorded and will be shared on different platforms in due course as well. So please do rewatch or share it with colleagues. That's helpful. And thanks again, Niels and Simon.